Hello, I'm Dr. Russel Libby, and I welcome you to the world of medicine. If you're like me, there are going to be nights in a week where you might have a disturbed sleep. You might get some pain, maybe a knee, a hip, shoulder. You get up in the morning, you're still a little stiff. You may have to take a warm shower just to sort of get things loosened up. Maybe a little exercise helps. And as the day goes on, you feel a lot better. You don't worry about it too much until you grab that plant sprayer and you realize, gee, that hurt yesterday and I can't do it like I did yesterday. It really hurts my finger right here. And these are kinds of things when we call pain in a joint that we term arthralgias. Now, arthralgias sort of happen. I mean, they happen to people all the time. When they become more chronic or persistent and there's inflammation in that joint that causes some of that pain, we call it arthritis. Show today is going to cover arthritis and the variety of conditions, of which there are close to 100, that might be associated with arthritis. Now, some of them are pretty straightforward, pretty simple, and some of them are fairly complicated and associated with some significant other medical problems. We're going to learn from Dr. Jack Wilkenfeld. He is our expert. He's a rheumatologist here in Northern Virginia, and a very good one at that. A fairly vanishing breed of doc who really has a very high level of information and clinical skill, a very important person to take care of these kinds of people. And we've got a great studio audience. We have people here who've experienced arthritis. They have a variety of conditions. They're going to tell you about how those conditions evolved, the kinds of things they did to get them treated, how they might have lived their lives to cope with these kinds of problems. And I'm just going to start by asking you, what kind of arthritis did you have?
I had and have osteoarthritis.
Osteoarthritis.
And I have gout, which is another form of arthritis.
Okay, so you've had two special kinds.
I really have.
Yeah,
it's
that's
been a
great.
ball.
And you, what kind of arthritis?
I have lupus arthritis.
You have lupus arthritis. So, and is arthritis a big part of your lupus experience?
My biggest part.
That's your biggest part, okay.
Rheumatoid arthritis.
Rheumatoid arthritis, Fantastic. Well, we're going to hear about everybody's diseases. Then we're going to come back and find out some of the details. And what kind of arthritis?
Mine is myositis condition.
Myositis condition. Well, that's a different one. That's one that is a little bit more exceptional. We're going to learn about that one as well. And you?
Rheumatoid arthritis.
Rheumatoid arthritis
yes.
as well.
Mine's osteo.
Osteo. So we've got a good assortment, good representation.
Lupus.
Lupus.
arthritis.
And lupus.
And lupus. Okay. Well, Dr. Wilkenfeld, give us a little perspective on the types of conditions that we associate with arthritis.
I'd be happy to, Russ, and thanks for inviting me, and I'm glad your show has decided to talk about arthritis in general, because I think it is a pretty important illness in our community. We have something like 50 million Americans that have arthritis at this time. Just about everybody in every family knows somebody that's affected by it. And the point that I would like to make about it is that arthritic pain can be pretty severe. A joint doesn't always look uncomfortable. If you look at it, a hand may be swollen. You're sort of looking at it and saying, well, gee, is that hand really swollen or not? And the pain that can be associated with minimal changes by appearance can be very intense. I think as you talk to the members of the audience, you're going to get a sense that, hey, this is not a little bit of a problem. It really is a pretty significant abnormality that you have to deal with on a day in and day out basis. And a lot of patients will tell you that arthritic pain is as severe as any pain that they've experienced. So, I'm glad to have the opportunity to be here, and I'm glad to be able to talk about arthritis in general, because I really think it is a pretty intense community problem.
Tell us, well, we heard rheumatoid arthritis and myositis and lupus. That's a classification versus the osteoarthritis. What are the common causes of arthritis?
Well, as we see from the audience, there may be 100 different types of arthritis. We have sitting here represented osteoarthritis, which is the most common and is commonly called degenerative arthritis, which implies wear and tear disease. rheumatoid arthritis is probably the second most common form of arthritis, but we also have metabolic disease like gout, and gout is probably the most common metabolic illness. When we say metabolic, we mean there's a disturbance in the body's chemistry. With gout, it's obviously with uric acid when the levels get too high and can precipitate a very painful crisis, which we call the acute gouty attack. Has it been the worst pain you've ever had?
It's been close to it.
Well, tell us a little bit about it. I mean, this is a really exceptional event, and it's pretty sudden in its onset for most people.
You wake up one morning, and all of a sudden, you think you broke your toe.
Yeah, and that's a pretty common description.
And that you get up and you try and walk, and you can't walk on that foot. And you think of what you did to break your toe.
What did you
and
kick?
you can't figure it out.
Right.
Was I playing basketball, 10 years ago? What did I do? And having no experience with it, you walk around, and I got crutches, and I was walking around on crutches, and finally I called the internist who said, "You've got gout," and he sent me to a rheumatologist, and that they treated it with some medication, and they put me on a regular medication routine. I take a pill a day for it, and
it works.
hasn't acted up.
Well, we're going to hear some more about
It's
that.
interesting, Howard. I'll tell you that there was a guy in the 17th century named Sydenham who described a classical attack of gout pretty much as you just said, that you go to bed, don't really feel very much, you get up, you're awakened by the most intense pain and discomfort. You don't want anyone to come near you. You don't want people to walk too briskly in the room. You don't want the sheets to touch your foot. So your description was pretty classical.
And it is very painful.
Yeah. So it goes
Anybody
back
else
to the
have
17th
had
century.
a gouty attack? Nobody's experienced it here. It's fairly common. The beauty of gout, you see these pictures of old Merry England with some English lord with his feet up on a big pillow and, of course, a nice snifter of port or something to help kill the pain. But that's a telling story in and of itself.
Yeah. What's interesting about the association between gout and high living, alcohol and rich food, is that during the 17th, 18th, 19th century, the better alcohols, the better liqueurs were distilled with lead pipes. And lead, as most of the physicians know, actually has a deleterious effect on the kidney. The kidney is involved in the excretion of uric acid from the body. The kidney function is impaired, the levels of uric acid can rise and can help precipitate an attack. So some of the interesting association of gout and rich living and alcohol is related to that, although alcohol does have some direct effects too. But
So normal kidney function and also the foods that create the kinds of that have the kinds of substances that become uric acid are important purines, as they say, meat products and some of the richer foods that are common in the diet of people who suffer from those things. Have you found that your diet affects the onset?
I can't tell because when I went on the medication, it stopped.
So, and that works well. And yes, I'm sorry.
So it was hard to tell. It was hard to tell what brought it on.
Right.
I just know what stopped it.
Right.
yeah, gout's a pretty nice disease for us to treat because we're pretty successful at it.
And we can make it happen.
Yeah, and it's gratifying. I mean, the patient comes in, they're suffering, and you know what? We have some pretty good therapy for that, and it isn't all that complicated.
So the age range is generally men, somewhere from the late teens through, what, the 50s?
Well, typically, it starts after their 50s.
Right.
No, I mean, if there's a strong family history of it, you can see it in the 20s, 30s, and 40s, but the most typical onset is after the age of 50. It's very uncommon in women before the age of menopause. I mean, a 25-year-old woman who comes into the emergency room with a very hot, swollen, painful knee is very unlikely to have gout. I mean, I've
and the
seen
knee.
one or two cases of it since I've been practicing.
Right. The knee, the big toe, the base of the big toe, the ankle, those are the major joints. You're going to see it in elbows, shoulders?
Well, actually, the further from the heart,
Yes.
the more likely it is to be gout.
Okay.
So the big toe, which is about as far away as you can get.
Keep it that
So,
way.
yeah.
Okay.
So we use the word distal, which means distant. The further it is from the central parts of the body, the more likely it is to be a gouty joint.
And fortunately, it's diagnosable quite easily and treatable, which is great. So that's one of the metabolic types. You were talking about the degenerative, as in the osteoarthritis, and then the autoimmune, the immune-related diseases, like the rheumatoid arthritis, and we're going to learn more about that. Infections, do you find infections precipitate joint problems?
Well, the one that most people are hearing about now is obviously Lyme disease. Lyme is caused by a deer tick, the bite of a deer tick, and then there's an infectious particle which is called Borrelia, and Borrelia has actually some relationship to the spirochete that also causes syphilis. Now, I don't want to say that. I don't want anyone to leave.
Where have those ticks been playing? That's the question. Yeah,
Exactly.
right.
They are entirely different, but it's a microorganism similar in appearance to the organism that causes syphilis, and it's transmitted by the bite of a tick.
And we'll talk more about that. And some of the viral diseases also. I mean, you can get arthritis from a number of different types of diseases, but are they chronic forms or more transient?
It's interesting. For the longest period of time, we thought that the viral arthritides, the forms of arthritis caused by viruses, are self-limited. But there have been some reports of parvovirus, which does everybody know what parvovirus is? It's Fifth's disease. Fifth's disease
It's a pediatric disease.
Dr. Libby knows.
Slap cheek type disease. Most people will have had it by the time they're 6, but not everybody.
Yeah, it's the same virus that causes Fifth's disease or the slap cheek type appearance in kids. And some patients that have parvovirus can actually go on to a more chronic form of what we call synovitis or swelling of the joints. But for the most part, the nice thing about the viral illnesses is they are self-limited. They don't last as long as, say, a disease like rheumatoid arthritis or one of the other major inflammatory diseases.
So we have, I guess, well, the degenerative diseases, and I don't mean to pick on you for being degenerative, but you did say you had osteoarthritis.
I'm falling apart.
Right, that's it.
Yes, it's osteo.
Yeah,
That's right.
and do you have any recollection as to when you started to suffer? Was this something you can identify with a particular joint and a particular episode in your life?
The back probably first, because I just didn't take care of my back. You know, being a homeowner, I was always twisting or bending and lifting wrong. And from there, I've got bad knees from jogging and feet to boot. Yeah, so I've done it to myself, I think, basically.
So it's a side effect of being healthy
I think so. I think so.
and living a long, healthy life, really.
Well, try.
So did you have a lot of history of arthritis of this nature in your family?
Not that I recall at all. I'm the first one, I think.
And where is your major pain now?
In my knees, and that's where Dr. Wilkenfeld is treating.
Okay.
With, so I think that's come from pounding the pavement with jogging. So
there came a point where the pain was severe enough and debilitating enough.
Oh, yeah.
What was going on? I mean, how did that start? So was it just, it would ache when you played basketball at first, or was it that you would sleep and your knee would really start to ache and throb and you were unable to go up and down stairs? What was the story? How was
all
that
the
going
above.
on? All the above, okay.
Yeah, pretty much, that's right.
And were you self-medicating, taking aspirin, Tylenol, Motrin, that sort of thing to help take care of that?
Tylenol and Aleve.
Yeah.
And it seemed to help a lot, but I was taking too much of it, so I had to back off a bit.
So you're getting a little worried about those things. So how did he evaluate? How did Dr. Wilkenfeld evaluate it first when he was
I went to him after I saw a orthopedic surgeon, and they always think operation or surgery, and I wanted to exhaust every other avenue I could.
Of course.
And fortunately, my wife was seeing Dr. Wilkenfeld for about 15 years, and he was kind enough to take me on as a patient and inject my knees with this Syndic, is it?
Synvisc.
Yeah.
Oh, it's good stuff, right?
Well, I've had 2 injections,
And so far?
it's doing well. I think it's not a perfect thing, but I can stand some pain.
Right. So it's getting a little bit better. Well, you still have a few more to go. It's an interesting phenomenon here. So we're talking about a degenerative process. How do you evaluate when people come in and you have to get sort of a baseline to understand, is it a degenerative joint? Is it an immune issue? What's the workup entail?
Well, the most important thing, of course, is to sit down and talk to the patient. And what Dr. Libby is referring to is, on the one hand, we have what we call mechanical pain, wear and tear pain, degenerative pain. And on the other hand, we have inflammatory pain. Inflammatory pain is sort of an internally derived problem. It's an illness. Rheumatoid arthritis is an illness that can affect your entire body. Systemic lupus is an illness that affects your entire body. And as part of that illness, joints become painful, red, swollen, and tender. So the first question I ask myself when a patient comes in with joint pain is, are we dealing with mechanical or wear and tear pain, or are we dealing with something that looks like it's going to be systemic or body-wide? And there are some important questions that we ask during the history. And I think really the most important question that I'll ask everybody is, are you stiff when you get up in the morning? And everybody will pretty much shake their head yes and say, I'm stiff. The major difference is that in mechanical pain, you can pretty much walk out that pain pretty quickly. Usually within 5 or 10 minutes, patients are beginning to feel more comfortable. They're able to move around a lot better. But patients that have significant inflammatory arthritis will tell you that stiffness will last for more than 30 minutes. It may go on for hours at a time. And there is a little bit of a difference in the distribution of their joints. So if I ask them where their hand hurts, certain joints are inflammatory. These knuckles right here are almost invariably related to inflammatory disease. The ones down here could be either, but are more typically affected by osteoarthritis. So knowing the distribution of pain, which joints are affected, how long morning stiffness lasts, can actually give you the type of clues that we're looking for. And then we'll also ask about rashes or other systemic abnormalities. Do you have a low-grade fever? What's your energy level like? Is the arthritis affecting you in other areas besides just the joints?
So it's an art form, a clinical interview and getting a history. And it really gives you a lot of your answers, and they say, 90% of the diagnosis can come from the history, and in this situation it certainly is true. Do you do lab work? Do you do x-rays? Do you do any other kinds of workup routinely?
Well, after the history, certainly you want to go in and examine the patient, and you should be able to tell from examining the patient the difference in feel. I mean, typically an osteoarthritic joint will feel differently than an inflammatory one will. So, and again, you look for other evidence of systemic illness. You also look for evidence of diseases outside the joints, like thyroid disease, for example. I mean, people don't think of thyroid disease as causing joint pain or muscle pain, but it's in that list of 100 different illnesses that can cause joints to hurt. So you want to be on the lookout for things other than just the musculoskeletal system. And then after you do a physical exam, certainly the laboratory can help us. There are markers in the blood that suggest the patient has inflammation. And I'm sure just about everybody in this audience knows those. Anybody? What's the major marker of inflammation in the blood? What test do we usually do? There we are, Mary Sue. Huh? Sedimentation rate. And another one that's really common now in cardiovascular disease. Anybody? The cardiologists have taken this one from us. CRP, right? CRP levels as a marker also of cardiovascular disease, it is a marker of inflammation. And what's helpful about the SED rate and the CRP level is they also help gauge disease. So if somebody comes in and they have arthritis and you're treating them and they're getting better, we like to see the SED rate and the CRP levels go down.
So with the osteoarthritis, you're going to come in, you're going to have a fairly normal set of those inflammatory parameters, typically, unless you have a combined disease, of course.
Right.
And then do you do x-rays or any of those types of things routinely? Do they help?
In the very acute setting, x-rays probably will not help you very much.
Okay.
But as the illness progresses, we start seeing changes by X-ray, and we can tell the difference between an inflammatory-looking joint abnormality and a wear and tear joint.
So in that wear and tear joint, you have a nice surface on a bone, and as time goes on, the pressure and sort of shearing forces of just normal motion, or sometimes even an injury, will eat away at the surface lining that bone that keeps it nice and smooth and slick.
Right.
Your body doesn't replace those cells as they lose them.
Yeah, those are cartilage cells, of course.
Right.
And God gives us one set of cartilage, and it's across the entire joint. And as Dr. Libby says, as that cartilage is eroded or denuded, we can't replace it. I mean, we're working on that. There's a lot of research being done in an attempt to try and have the body regrow cartilage. But as of now, if you lose it either from wear and tear, or if you lose cartilage because the joint's inflamed and it's sort of digested away, that replacement at this time is not repairable.
Right. And of course, just to stay on that same line, when you talk about cartilage degenerating, some of the therapies that people endorse and like to try are those that provide nutrients that may be the basis of the molecules, the chondroitin and glucosamine that people like to take to try to help their degenerative joints. Those are all the substrates that the molecules of cartilage are made of.
Well, that's actually the basis of what Mr. Davis was talking about. Synvisc injection is hyaluronic acid. Hyaluronic acid is a normal component of a joint, and we're putting that molecule back into the joint. Now, we don't know exactly how it works. It's not just a lubricant. It has other functions that we're not entirely clear about, but we do know that if we give it back to a patient by putting it into the joint, we can help alleviate pain and discomfort. So that's kind of what you're referring to. And of course, if we fail, like your brother's hips failed.
And your hips, you didn't even know you really had hip disease.
No, I had the osteoarthritis of the back, and I had 2 back surgeries, and I walked around in unbelievable back pain, and I started getting this groin pain, and I thought that I'd pulled a groin muscle, and finally I went to see an orthopedic who just gave my leg a little twist and says, "You've got a bad hip." And eventually I had both hips replaced, and the back pain disappeared. And I'm still trying to figure out how that happened. But I'm happy that it did.
Don't ask questions.
I'm
just
not
be
going to
thankful.
ask any questions.
That's right. So, there were 2 things that came out there that are pretty interesting. One, of course, is the fact that you can, at the next phase, if a joint doesn't work, well, we have some technology now that lets us say, okay, we're going to give you new joints. Doesn't mean you look any younger, so don't worry about that, but you may feel better about it any which way.
Just a face guy.
That's right. But nonetheless, there's that, but also osteoarthritis of the hip giving you groin pain. I mean, I don't think people realize the way that pain can be distributed when you have that kind of injury.
Yeah, it's an interesting discussion that I've had many times with patients. When they come in and tell me they have hip pain, and they go like this, and they say, "Oh, my hips are killing me," and I say to them, "Well, where exactly is your hip? It's not in your buttocks. Your hip is in your groin." And you can all feel that when you get out of a car and you swing your leg out. You can, if you put your hand deep into your groin, you can actually feel the ball and socket of the hip. So the question that I always emphasize is, does it hurt here and here, which tends to indicate hip joint pain as opposed to spinal pain? It can sometimes be difficult to differentiate. I don't want to say it's always easy, but hip pain tends to be more in the front. Spinal pain tends to be more in the back.
It absolutely fooled me.
Yeah.
Well, you've had arthritis, but you don't look like the type who would be waking up in the morning stiff with these old and worn out joints the same way.
Well, with lupus, you do have that too. My fiance and I, he helps me get up in the morning because I just, my body hurts, but it's with lupus, so it's basically everything hurts. And it's hard to get up. Everything's kind of like heavy. And so takes a long time to just sit up and then straighten my legs and try to get up and then try to walk and stuff. So yeah, at 27, I was diagnosed when I was 18.
Well, give us a
And
little
it's-
perspective there. So, as a kid, you did all the normally active things. You're a dancer.
I was a dancer, yes, with Washington Ballet. Yeah, I did ballet, and I also did musical theater, so I sang as well as danced, and I didn't have any problems. And then starting possibly before I was 18, I was having a lot of trouble breathing. I was having a lot of pain everywhere, and doctors thought I was just stressed out, or, oh, you're in college, and, and I was in New York, so, oh, you're just, running around and stuff. And I went through to a lot of doctors, and finally, through the blood test, whatever
Said
it
rate
is. Yes.
Showed something a little
Yes,
strange and
yeah.
kept looking for things.
They kept looking, and they found it out. And so I still have, of course, now I don't dance. I do some singing, but definitely throughout the years of trying to battle lupus, definitely it's been a struggle.
You've had to find some other outlet.
Some other outlets,
Yes.
exactly, to filter that, yeah.
So your symptoms, well,
Mm-hmm.
just to say, with the joint pain that you have in the morning,
Mm-hmm.
you wake up with it, does it get better through the day? With activity? Take a hot shower, take a warm bath?
Yeah,
whatever,
taking a hot shower, moving around, definitely sitting down for a while doesn't work.
Right.
Stress-free, so stress to kind of de-stress things kind of helps it too. And also just to be happy,
Right.
kind of,
Okay.
that helps it too.
Well, you must tell a lot of good jokes.
Well,
He does.
she makes it easy.
She's got a good sense of humor.
Yeah, she's changed my outlook on life completely. You would never know it meeting her, all that she's been through, even to the fact of not related to or possibly related to lupus. When she was 16, she had major surgeries on her legs because of ballet. 3 different surgeries, gangrene, almost lost her legs.
So that's what doctors are thinking, that's possibly what triggered the physical stress on my body to kind of say, ooh, what's going on, and then eventually
Any
get
family
diagnosed.
history of lupus?
No, thyroid problems, but no lupus, no.
Well, that's
yeah.
still interesting in and of itself. We'll hear a little bit more about that. And you, how old were you when you started to experience some of the symptoms?
That was 2 years ago,
2 years ago.
and I was 45.
Okay.
And I started having these pain in my back. Initially, it was mild, and within 2 days, it became very, very severe to the point that I cannot turn my neck, and I cannot move my body, my whole body, the leg, the arms, the back, everywhere. And I was admitted to the ER, and at the time, they couldn't figure out what happened. I was there for 3 days. They ran through all kinds of blood tests, and finally, they figured out I have lupus.
So this was a fairly acute onset.
It was.
So, and prior to that time, you were a pretty healthy person.
Yes, all my life. The only time I was admitted to the hospital, well, not admitted to hospital, I went to the hospital was to deliver my boy. That was the only time, so it was a real shock to me.
And you had no family history of anything that you knew
No.
of that was related to anything like this.
No.
Okay, and that was 2 years ago. And how's the course of your illness been? I mean, you were in a lot of pain initially. Are you
Yes.
still in a lot of pain?
No, I've totally changed my lifestyle. I'm not working anymore, and so that helps. The stress level is a lot better now.
What kind of work were you doing?
I'm a computer software engineer.
Right.
Yeah. So initially, I thought the backache when it started it.
Right.
I thought it's related to my job,
Right.
so I just ignored it, and until 2 days later, it just became really, really severe.
Right. So people probably try a lot of different types of mice, different hand jobbies, maybe get different chairs, think that they're going to find some way to solve the problem. Oh, my knees have to be higher, my shoes have to be softer, whatever it is. But you were pretty miserable, and you had a pretty acute onset.
Yeah, and that's pretty common.
Is it?
Because patients don't always understand that this abnormality that they're experiencing in their hand is related to some intense inflammation. And they think, well, I can fix it with this, I can fix it with that. And it really doesn't go away until they actually seek medical attention. So your experience with that is not at all uncommon.
Now, was your lupus is acute and onset?
Yes,
Yeah.
very sudden.
And how long ago was that? That was
Almost 3 years ago.
3 years ago.
Mm-hmm.
Okay. And you were a pretty healthy person through all those
Mm-hmm.
years up to that time. And what was the circumstance when you started to have pain? Was it similar to the ones we
Well,
heard?
I also thought mine was work-related. I'm a nurse, and I'm on my feet all day, and suddenly one day my feet started hurting. So I thought I needed to get new shoes. So I tried new shoes, and that didn't work. And probably within 10 days, my hands started hurting, and then I knew something was wrong. So, because it was every joint in my hands and my feet. So.
Any other, well, we need to hear about
yeah.
lupus altogether and learn a little bit about what it is, what are the spectrum of diseases. Now, lupus is something more common in women. I mean, we have women here representing it.
It's about, the incidence is about 9 to 1 females to males. So it clearly is an illness of, that we see much more frequently in females. And it probably is estrogen related. Many women will tell you that at the time of their menstrual cycle, they'll notice a significant change in their symptoms. There have been some experiments actually in laboratory animals. There's a mouse called the NZB, white NZB black mouse. And what they found is that this mouse develops a spontaneous form of lupus. So a mouse comes down with lupus, and they realized if they took out the reproductive organs of a female mouse, if they took out their ovaries, their disease got better. If they gave that female mouse testosterone, their disease got better. And conversely, the male mice who also developed lupus had their sexual organs removed. Those mice got worse. So it seemed to be very much a hormonally dependent process, and we definitely see that in women. We don't treat lupus with testosterone. I mean, so let me just say that, don't ask your doctor for it, because testosterone is, as you know, is the steroid that the major league baseball players have been indicted for taking. So it's not safe, and it's not something we do on a regular basis. But the female predominance of it really does seem to be related to estrogenic hormone. The one thing I would also emphasize about lupus, it is what we would describe as the prototypic autoimmune disease. That's what happens in lupus. Well, for some unknown reason, the body starts making antibodies against itself. Antibodies are usually directed against harmful things like bacteria, viruses, invading organisms. And in lupus, for some really unknown reason at all, the body directs these antibodies against itself. And these antibodies, when we measure them in the laboratory, are called anti-nuclear antibodies. They're directed actually against the nucleus of a cell. We can measure them, and it's pretty helpful in terms of making a diagnosis. It's hard to make a diagnosis of lupus in the absence of anti-nuclear antibodies. Just 99% of patients with lupus will have anti-nuclear antibodies. Not everybody that has anti-nuclear antibodies, however, has lupus. There are false positives. But lupus does things to the body outside the joints, as I'm sure you've all experienced. We call it a systemic disease, systemic lupus erythematosus. And the systemic means it can affect parts of your chest, parts of your kidney, parts of the neurological system, the skin, the mucous membranes. So it's a body-wide abnormality. The nice thing in treating some patients is that it just stays at the joint. And that's actually kind of uncommon, because we would typically expect lupus to affect areas besides just their joints. And indeed, it's part of the definition of it. You have to have involvement outside the joints to really have a definitive diagnosis of lupus.
And lupus itself, of course, as you say, it'll come with the arthritis. Have you had any other organs affected by your lupus?
No.
No. Have you had any?
I have actually, when I was first diagnosed, I had kidney problems.
Okay.
And I also have, I have really bad asthma, so your diaphragm, your respiration is really bad for me.
And the inflammation there can actually cause some significant lung damage. I know that I did a show last year with a patient who had actually a lung transplant, who had lupus, who developed, I guess, the progressive changes that really required a significant intervention.
Yeah, lupus lung disease is one of the most severe complications of that illness. It can cause severe shortness of breath and destruction of lung tissue. Sometimes it just affects the lining of the lung. We call that pleuritis or pleurisy. Sometimes it affects the lining around the heart. We call that pericarditis. Pericardium is the lining around the heart. But if it affects the lung itself, yeah, that can be a very severe problem. And we can also see severe inflammation in the kidney. We can see severe inflammation in the neurological systems.
And you work with the foundation.
I do. I work for the Greater Washington chapter, which services Washington, D.C., Virginia, and Maryland.
The Lupus
Lupus
Foundation.
Foundation, absolutely.
And this is something you've taken upon yourself just by a grand interest and participating in that evolution of education and support for families and individuals with lupus.
Absolutely. My boyfriend's mother had lupus, so we lived for about 6 years with her lupus, and it's a challenging disease because these lovely ladies were very lucky in their diagnosis. A lot of women or a lot of people diagnosed go through numerous tests, years and years, couple doctors. So these stories are pretty exciting to hear that either doctors are becoming more aware and testing more frequently, because quite frequently it's challenging and proves.
You have to be lucky to be in a place where there are docs who are sensitive to the disease and understand it well enough, and then to be able to find a rheumatologist like Dr. Wilkenfeld who knows how to treat them as well. Are there special treatments that you use for lupus, things that might be a little out of the ordinary?
Well, what we like to do, of course, is try and tailor the amount of treatment that we give to the severity of the disease. And I think this sort of gives me an opportunity to say that not everybody that has lupus has a bad disease. A lot of patients will have just minimal involvement. I follow a lot of patients who really are on no therapy at all. And we just follow them over a period of time, and they continue to do pretty nicely. Other patients, the ones who we were alluding to before, who have major organ involvement, can have very intense and severe problems, and we will take out much stronger medications to treat those patients than we will to take care of a patient whose exposure is really pretty minimal. And it's just a hierarchy. You don't want to undertreat a patient because then they'll be unnecessarily uncomfortable, and you don't want to overtreat somebody because you'll expose them to medications that have side effects. So it's always looking for balance.
Genetics would be certainly a strong suit. If you have a family history, you should be sensitive to the fact that if you start to develop these symptoms, you should check them out. And sometimes family history isn't obvious because it may be a distant, or let's say a grandparent or someone who may have died early relative to your age. Are there other symptoms that people might be sensitive to? Rashes, the classic rash that people describe as the butterfly rash?
Right, exactly. I mean, the butterfly rash is the rash that affects your cheeks. It's a red rash. It spares this part of the part where your cheek hits your mouth. You can get sores in your mouth, joint pains, low-grade fevers, swollen glands, chest discomfort, abdominal discomforts. It pretty much is a system-wide abnormality.
And a lot of people might think they have fibromyalgia or some chronic fatigue kind of problem until they get those things checked out. So
I mean, that's where the laboratory can be very helpful. Again, to make a diagnosis of lupus, your anti-nuclear antibody should really be positive. I mean, it would be very unusual to have systemic lupus without a positive, this one particular laboratory abnormality. which is an indicator of these autoantibodies.
So if it's a consideration, most docs will use the laboratory and they will check for that sort of thing. Now, what you have is something that's entirely different. How did your disease, myositis, you're describing to us?
Well, about 33 months ago, I sort of felt like I fell off a cliff. Extreme fatigue came on very quickly, which, as I understand, is unusual for myositis. I was 59 years old, working as hard as I had all my life, been healthy all my life, and within about 2 weeks, beginning in February of 2006, I became close to bedridden. Over the next 4.5 months, I became much more bedridden, could barely speak, had trouble going up and down the stairs once a day at home. Ultimately ended up with blood clots from the sedentary nature for a while. My weight went from about 205 pounds down to below 150 in 4 months. I was having trouble swallowing.
Really scary.
Very much so for the family and somewhat for myself, although I was inclined to try to find the doctors and find out what was wrong and see if we could get it fixed.
You're his daughter. Were you living at home at the time?
No.
No? So you were hearing about this from a distance
Yeah.
and coming over to see it for a distance. And tell me what happened then.
It was scary watching him go through that. He went from so healthy to barely able to do anything real quickly.
You were
So-
probably thinking, what is going on?
Yeah, and not getting answers. Nobody really knew what was going on for a while, so.
So you were a pretty athletic, active person. I mean, you told me you had a TV career that was cut short.
Well, at about 11.
At about
yeah.
11, oh. And that was with athletic prowess and high jumping.
We lived in Omaha, Nebraska, and they had a playground championship, and I was the high jump champion in the 10 to 12-year-old group at my playground. So that one weekend, all the playground champions got to go on TV and compete with one another.
Wow, that's great. And I'm sure you don't have copies, but we'll make sure you get a copy of this one, at least. So your disease started that way. How did you end up being diagnosed?
Well, after about 2 months of watching a number of various blood tests, things were not improving or changing, and the doctors that I was dealing with then said, along with myself after an emergency room visit, it's time to get some more people involved, get some specialists in these various areas, and do a discovery process. And we went through a number of weeks of getting in contact with people like Dr. Wilkenfeld and his partner at that time, Dr. Grismer, neurologists, surgeons to take biopsies of various parts of my body. And also, my daughter was very instrumental in contacting NIH. And NIH was intrigued by the few-week onset for a disease that typically can be observed retroactively coming on over a 6-year period. Right. After I had a blood clot episode in June of '06, I finally got into NIH in August, and they involved me in a number of studies and examinations to try to pin down the actual problem that I had. I had been started on very heavy doses of prednisone and later methotrexate to try to overcome the weakness, the autoimmune problems that I was having. And through a series of tests and doctors and gradual improvement, I started feeling somewhat better by the end of that year. And then other problems hit. I don't know if you want to go into those or not.
Well, we'll save those for another show, but and we'll continue your television career that way. I will say, though, that you look wonderful now. You look like you've got your energy back. Looks like you've been able to get things back in order. So that's another one of those autoimmune diseases, a much less common one, I would suspect.
Definitely. I mean, the condition is called dermatomyositis at this point. Dermato refers to skin, myo refers to muscle, itis is inflammation. What we're talking about is inflammation of both muscle and skin. And the inflammation of the muscle injures it. And what Mr. Pearl had sustained, what he experienced, was very intense muscle weakness. It's the type of muscle weakness that prevents you from getting out of a chair. I mean, most people don't even think about that. I mean, to be unable to go up a stair, to get out of bed, to need someone's assistance, and otherwise an athletic, healthy individual all of a sudden to be laid low by this. And the reason for that is the muscle, when it becomes inflamed, becomes very, very weak. And this weakness was not just fatigue, it wasn't lack of pep or energy, it was due to actual muscle injury that was precipitated by one of these autoimmune illnesses that we've been talking about. And the issue here, the major necessity, is to suppress that inflammation in the muscle so that the muscle can return to normal function. And it's important not just for the muscles of the arms, but also difficulty swallowing, because you require muscle strength to do that. So it's a medical necessity to get that inflammation suppressed, and whatever medicines are necessary to do that, you just have to use.
Wow. And I'm sure in certain settings that people may not get the right treatment and may not actually survive it.
It can, thankfully not very much anymore, but before the modern era, certainly, it was a very, very dangerous disease.
Right. So rheumatoid arthritis,
Yes.
that's one of the special arthritides, as they call them. And when do you think you started to have symptoms of rheumatoid arthritis? How long ago?
I was hit with a tsunami, a wave of it, in September 2004.
Okay, so you lived a very healthy life.
Very
Never had
healthy.
Any suggestion of any kind of
No
even
problem
osteoarthritis?
nothing whatsoever.
So, and how did it come on for you?
I was sitting at my desk at work,
Yes.
and I couldn't walk. My joints were totally inflamed. I couldn't get up out of my chair, and I was covered with cellulitis, which was, I guess, a skin infection. It just hit me that afternoon.
You mean you got up that morning,
I went to
had breakfast,
work.
your coffee, went to work, and everything was fine, and then by the afternoon, that was it?
We were getting ready for the board meeting 1 minute, and the next minute I was on the way to the hospital.
Wow.
Yeah.
So nothing ever had given you any indication. And were you in fact infected? I mean, did you have skin infections or
I was
joint
in the
infections or
hospital for 5 days.
Right.
They were with the IV antibiotics to
Right.
get rid of the infection, yes.
So they figured you had a cellulitis. They had no suspicion at that time you had rheumatoid arthritis.
When I went to the emergency room, the doctor looked at me and said, "This is advanced syphilis."
Oh, really?
Yeah.
Oh.
So
Wow.
I am thinking
Wait,
like,
you were,
That wasn't us. I don't think we had any part in that one.
and I said, well, I'm probably the last person in the world that would have this. And I was told that she had seen it many times, and that's what it was.
wow.
Yeah.
I didn't realize, well, so you
just
dispelled
goes to
that
show
really
you.
quickly?
Well, they kept me in the emergency room for hours and hours, and I was really in so much pain. I don't remember it too well, but they did come back and say, well, they guess I didn't have syphilis, and they were admitting me to the hospital.
Right.
And I was there for 5 days, but I was in and out for 2 years.
So tell me, did you get better during those 5 days with IV antibiotics?
I got well enough for them to discharge me from
I
the
think
hospital.
you were going to recover completely. at that
Well,
point.
they didn't give me a diagnosis, but they said I could go home.
So how soon after that did you start to investigate and discover other possibilities? I mean, did you have other symptoms that evolved over that period of time?
Well, I kept ending up back in the hospital
With
the same thing.
the same thing?
Yeah.
Same spot?
The rash on the lower extremities and the swollen joints, inflamed swollen joints in the feet. Yeah. So it was obvious that there was something really wrong, and we needed to find out what.
Wow. So how long did it take you before they finally made it the accurate diagnosis?
2 years.
2 years.
Yeah.
So 2 years in and out of doctor's offices, in
in
and
and
out
out
of
the hospitals.
lots of antibiotics, people telling you had Lyme disease, I'm sure, over
I
and
was
over again.
treated for Lyme disease, yes.
Probably even had IV therapy at
I
that
did,
point.
yes,
Ceftrax and IV. And you were probably held up on one of the websites says, look at this poor person, 2 years, and they still aren't better. We got to keep treating her for another 2 years. And nothing was making it better, really.
I was taking 22 pills a day.
Yeah.
My weight dropped. I was emaciated. I could hardly make it through the day. And I was having, at night, waves and waves and waves of excruciating pain. And my joints would just become so inflamed. And 3 times, I drove myself to the emergency room in the middle of the night, and I couldn't hold the steering wheel. I did it with my wrist like this, and I begged them for morphine. 3 times I had to do it.
Boy, you're really developing a reputation in the hands of emergency room, I have to say. Wow.
Yeah, but, you know, that's how bad it was.
Yeah.
I remember thinking, this is worse than childbirth.
Which is sort of the first point that I had made when I started talking about arthritis, is that people underestimate the severity of pain. And I think you're a graphic example of that. I mean, this pain is nothing to sneeze at. And it persists, which is a lot different than other day after day, and be incapacitating.
So you basically have not had a lot of the other changes that some people may experience with arthritis. Joint pain in the hands, deformities, things of that nature.
I'm doing very well because I'm on a medication that really helps me. So I think I'm doing great.
Good.
And I don't suffer many symptoms now. I might have had more symptoms, except there are new drugs now
Right.
that are very helpful.
Okay. Well,
Yeah.
we're going to hear a little bit about that too. I know that you've had rheumatoid arthritis for a longer period of time.
Yes, about 16 years.
16 years. And how did yours start? Do you remember?
Oh, absolutely. Both wrists, I had a little aching going on and that sort of thing that you kind of live with. Everybody does. And then it just got to the point where both my wrists were so painful, I really couldn't tolerate it. And at that point went to the internist, and he diagnosed me with rheumatoid arthritis, and he sent me to the best doctor immediately. And he, but he really got me on track. Right. Yeah.
And so you had been suffering with joint pain, and you can see, as I was saying, your hands have suffered the most.
Yes.
Is that where you've suffered the most in terms of joint
Well, feet. I've
inflammation?
had
Your feet as well?
foot surgery.
Right.
Yeah,
Okay.
and that helped tremendously.
Okay.
Yeah.
So
And,
you've had to deal with it. Your hands look pretty healthy at this point, and you've been fortunate.
I've been fortunate because I think there are treatments available to me that were not available to you.
That's right. Early on, there was almost like a rheumatoid being the stepchild
Right.
in the arthritis field, and since then, it's been wonderful developments.
And I guess it's worth spending a couple of minutes talking about some of those developments as they have occurred. I mean, rheumatoid arthritis, certainly, people talk about rheumatism and those body aches that Granny had, and she had the little deformities, and I think your hands, as dramatic as they are, really represent what the traditional or conventional expectation would be with arthritis of the hands.
I'm kind of fortunate to be able to practice now because we really do have medicines that are available, as you so nicely described, that can really suppress the disease. As a group, they're called biologics. I'm sure everybody has heard about them. They've been on all the television commercials. The 3 best-known ones are Enbrel, Humira, and Remicade. They all work by inhibiting a molecule called tumor necrosis factor. TNF is a very powerful stimulant of inflammation. It's like it turns on inflammation throughout the body. And in the case of rheumatoid arthritis, it's going to be in the hands, the wrists, and the knees, ankles, and feet. For us to have a medicine that's so effective, it's like the specific bullet that turns off this molecule and makes patients feel a whole lot more comfortable is really a godsend. But part of the difficulty I have when I sit down and talk to a patient is to tell them that I would like to give you a medicine like this, but it has side effects. And you know, that's always the other edge of the coin. And so part of what I do is I have to be a salesman. And I have to say to a patient that, yes, I understand that there are side effects of any of the medicines that we use, but in this case, the medication really, the benefits of the medicine really far outweigh the potential risks. And you know, for so many patients, not unfortunately for everybody, but the response rate has really been great. And I think the side effects, thankfully, have been for the most part pretty manageable. We have not seen bad things happening on a regular basis.
And I would say that it's a very dramatic change in terms of how we can really look at these patients in their life perspective, to be able to keep them active and healthy, to keep from those secondary kinds of problems from occurring. You've really got an incredible golden apple with which to deal with a lot of those things. There are so many more things that we could talk about. People are always wondering whether diet has something to do with these kinds of diseases, and I don't think that there's a lot of information to support that. People wonder if diet can cure these diseases, and I don't think that there's any evidence that that's the truth either. But there are many more things for you to learn, and certainly I hope that you've been able to come to the conclusion that there are symptoms that you can experience that do need some further evaluation, and that there are physicians out here like a rheumatologist like Dr. Wilkenfeld who can help you come to some determination as to what is going on and help guide you with the right choices both in diagnosis and treatment. I do thank you all for being with us. It's been great, wonderful stories. It's been a pleasure, and it's been a pleasure having you, Dr. Wilkenfeld. And
Thank you,
it's been a pleasure having you with us. And until the next time, I'm Dr. Russell Libby, looking out for your health.